So I'm going to do my talk today on iodinated contrast, obviously, particularly on the use of iodinated contrast for computed tomography. Okay, so what is IV contrast? It's a form of intravenous radiographic dye containing iodine, which enhances the visibility of vascular structures and organs during a radiographic procedure. And basically it just stops or limits all of the X-rays passing through vascular structures. There are lots of different types of IV contrast. The type that we use is iohexyl, and it's very dependent on individual department protocols, patient weight, and the type of scan being performed. So iohexyl or omnipaque, and the main two we use now are the 300 or the 350. Okay, so iohexyl, it's a non-ionic water-soluble contrast medium, and because it is non-ionic, it has a much lower osmolality. So its elimination half-life in patients with a normal renal function is actually 2 hours, so that's pretty good. So basically what that means is that within 2 hours following your injection, half of the contrast has been broken down. Okay, so this is pretty cool. Within 24 hours, 87 to 99% of the injected iohexyl contrast is excreted via the kidneys. And the maximum urinary concentration is achieved within 1 hour. So your large majority of it is excreted through the kidneys into your bladder within an hour, but within 24 hours, pretty much all of it is gone. So that's just the chemical formula of iohexyl. Okay, so warm IV contrast. Why do we keep our IV contrast in the warmer? So we try and keep it to a temperature that's similar to the human body, and this actually decreases the viscosity of the contrast media. What does this mean? So it has a few good things. It can result in lower injection pressures. So that's our line that comes up on our injector rate. It can minimize complications and actually improve the vascular opacification for injection rates greater than 5 mils a second. It can allow direct arterial injections through smaller caliber catheters. So we can inject through, 22 gauge and things like that without maximing out the pressure. It can improve arterial studies where the timing and peak enhancement are critical. And some studies have shown that when using very viscous contrast media, warming it may reduce the risk of extravasations by 3. So that's pretty impressive. So this is just an idea, a quick table to show you. So our 300 strength contrast at 20 degrees, or like a cool room temperature, it's actually 11.6, and at our 37 degrees, so out of our warmer, that drops to 6.1. So that's almost half. And with your 350, from 23.3 down to 10.6. Okay, when do we use it? So when we're looking for any type of vascular pathology. So some examples, looking for space-occupying lesions or arteriovenous malformations, aneurysms, brain perfusion studies, PE studies obviously, any sort of aortic study. In your abdo-pelvis, it's mainly, aside from aortic studies, it's mainly things like malignancies, GI, what's the word I'm looking for?
GI bleeds?
Yeah, bleeds, yep. And for our extremities, long leg angios or upper extremity angios, things like that. Okay, phases. So there's 3 main phases that we use the IV contrast in. Arterial, which is again very dependent on individual and department protocols. Venous, and delayed. Contraindications. So if your patient has a history of renal disease, and particularly if the patient is diabetic, that's a big contraindication to IV contrast. Certain nephrotoxic drugs, so an aminoglycoside is actually an antibiotic. It's a collection of antibiotics, but one of the main ones is streptomycin, which was actually used originally to treat TB. So it used to be quite common. Dehydration, poor cardiac status, and in particular congestive heart failure. Multiple myeloma, hypothyroidism, so that's high thyroid, not low. And it doesn't matter whether it's a known or even if it's just suspected, we need to know about that. And recent contrast injections that are greater than 120 mils within the preceding 24 hours. So there are three main reaction classifications. We've got mild, moderate, and severe. So some of the mild classifications is a flush, patient feeling unwell, nausea, severe itching, headaches, and the development of rash or hives, so mild rash or hives. They all generally resolve without needing specific treatment and are seen in roughly 1 in 100 patients. So not all that common, but not all that uncommon either. Okay, moderate. So severe vomiting, marked hives and rash, bronchospasm or respiratory symptoms, so the patient starts to feel difficulty breathing, facial and laryngeal edema, so things like swelling of the face and swelling of the throat, and a vasovagal response. So these are seen in roughly 1 in 1,000 patients. Then we've got severe, so hypovolemic shock, which is actually secondary to vasodilation, respiratory arrest, cardiac arrest, and convulsions. These are quite uncommon, and these are seen in less than 1 in 100,000 patients. Okay, so our current contrast media are mainly considered to be low osmolar and non-ionic, and because of this, it's considered to be 5 to 10 times safer in regards to experience mild to moderate reactions. However, if a patient has a history of previous reaction, a recurrent reaction is considered to be 8 to 60% more likely. Also, if a patient has a history of multiple allergies, there is considered to be a 3 to 5 times increase in the risk of having an acute reaction to IV contrast. Most of these reactions, though, are classified as mild, so that's the 1 in 100. And an allergy to shellfish or topical iodine antiseptic are no longer associated with an increased risk of reaction, and that's because it's a completely different type of iodine. Okay, so our new CT booking form that came out, a couple of months ago? Yep. So we're going to go through a couple of these questions and why it's important to ask them. Okay, so asthma is one of our first questions. So if a patient has a history of asthma or multiple allergies, it increases the risk of a contrast reaction, and this is mainly bronchospasm. So with a history of asthma, which is mainly uncontrolled or quite severe asthma, it actually can increase the patient's risk of a reaction 6 to 10 times. So it's something to be aware of, and we are talking mainly about uncontrolled asthma or poorly controlled asthma and quite severe asthma. The positive thing about this, and why we don't need to stress a huge amount, is because patients with that type of asthma generally are taking medications every day and they carry them with them. So things like your bronchodilators. Okay. And diabetes. So our main concern with diabetic patients is whether they are taking a metformin-based drug. Approximately 90% of metformin is excreted via the kidneys, virtually unchanged within 24 hours. And metformin stimulates the intestinal production of lactic acid. So if you've got a patient with poor renal function and then you give them iodine contrast and that causes renal failure, you can actually completely stop the excretion of metformin, which causes it to increase the levels within your bloodstream and can cause severe lactic acidosis, which can be a life-threatening condition. So the most severe effects of lactic acidosis are breathing difficulties and a slow or irregular heartbeat. So the new guidelines that have come out for the Royal Australian and New Zealand College suggest that metformin should only be ceased if a patient's eGFR is less than 30. However, this is different to our Queensland Health guidelines. Okay, so heart, kidney and thyroid. So your heart, and particularly severe cardiovascular disease or congestive heart failure, can result in a hemodynamic change or arrhythmias. And congestive heart failure can result in poor renal perfusion, which increases the risk of contrast-induced nephropathy. Your kidneys. So if you've got kidney disease, then you can have an increased inability to excrete the iodine contrast, which can obviously result in an acute kidney injury because it can't clear the contrast from your system. Thyroid. Patients with an untreated hypothyroidism or a hyperfunctioning thyroid nodule, which can include multinodular goiter, are at an increased risk of thyrotoxicosis. So thyrotoxicosis can actually cause a thyroid storm, which in turn results in heart failure and myocardial infarction. So it's a pretty big deal. And the thing that I didn't know that I found quite interesting, and this timeline varies a little bit, but thyrotoxicosis doesn't actually occur immediately following your contrast injection. It can actually occur 3 to 6 weeks, and in another article I read, actually upwards of 1 or 2 months following your contrast injection. So it's important to be aware of that because that needs a long-term follow-up with your patients. Multiple myeloma, sickle cell and polycythemia. So multiple myeloma, the main problem with this is if the patient is dehydrated, because it can significantly decrease your renal function and cause irreversible renal failure. Sickle cell means that the patient's renal function should be checked. Other than this, the only real problem if a patient has sickle cell is that they can actually get a worsening in the pain they feel from their sickle cell. Polycythemia means that the patient can be at an increased risk of experiencing a reaction. Other than that, it's not a necessary reason to not give contrast. It's just something you need to be aware of, that the patient is at an increased risk. Pheochromocytoma. So these can secrete catecholamines, which can induce life-threatening hypertension. And the problem with this is only when we inject directly into the adrenal or renal arteries and veins, as this can cause a hypertensive crisis unless the patient is treated with these specific drugs. So otherwise, if you're just doing a normal intravenous injection, it's not a big deal. It's only if you're injecting directly into your renal arteries or veins. Okay, are you currently on any medications? So aside from finding out about your metformin-based drugs and things like that, there are 3 main drugs that you need to be aware of. So we've got nephrotoxic drugs. That's that antibiotic we were talking about, like your streptomycin. So when they are combined with IV contrast, they can put the patient at an increased risk of acute renal injury. Your interleukin-2, which is a cytokine, so that's a chemo drug, and it's used to treat cancers, mainly things like renal cell carcinomas and melanomas. It actually reacts with the iodine, and that can happen several months after the IV contrast injection. Most of the reactions seen are simply flu-like symptoms and skin reactions, but it's still something to be aware of. And your beta blockers. So this is an interesting one, and it can be quite fatal to the patient because it actually can change the way you would treat the reaction. And instead of giving, if you've got a patient that has a severe reaction and they're on beta blockers, you don't actually want to give them adrenaline. You want to give them its glucagon. Okay, because if you give them adrenaline, it actually causes their heart rate to pretty much skyrocket. So you need to be aware that they're on beta blockers so that you know which way, you can tell your team which way they'd need to treat the patient. So it also can have the effect of patients may present with like a vagal reaction, and if no one knows that they've had IV or that they're on beta blockers, they may not know that it's an actual reaction to the IV contrast. So points to consider. So myasthenia gravis is no longer considered to be an actual contraindication, but the main thing you can warn a patient about is that if they have this condition, then they may see a worsening of their symptoms, things like breathing difficulties. Breastfeeding is no longer thought to require the mother to stop breastfeeding or to express their milk and get rid of that, because it's actually been found that less than 1 in 1,000th of your contrast enters into the breast milk. So they consider that a negligible amount. Pregnancy, aside from the obvious one that you don't really want to be scanning a pregnant patient or a fetus, if it needs to happen, then once the infant is born, it should receive a hypothyroidism test during the neonatal period. We don't really need to worry about this here because in Australia and New Zealand, it's actually part of the guidelines that when a new baby is born, they do these tests anyways, routine. eGFR and creatinine. So it's the estimated glomerular filtration rate, which is basically an assessment of kidney function. Your creatinine is similar, helps to determine whether your kidneys are functioning normally. Normally functioning kidneys remove creatine from the blood and maintain that normal level. So if you've got a change in your creatinine, you know something's not quite right. However, eGFR is considered to be the most reliable source of kidney function, as it doesn't just take into account what your blood level of creatinine is, it also takes into account your patient weight, age, sex, and race. So the current guidelines from the Royal College. So if your patient has a history of dialysis, a kidney transplant or a single kidney, renal cancer or renal surgery, a history of diabetes, or is taking metformin, then they say you need to have a recent eGFR within 1 month, unless it's an emergency situation. So pretty much the Royal College has come out and said, in any sort of emergency situation, if it needs to be given, you need to give IV contrast. And they disagree that age should be considered when looking at whether you need an eGFR or not, because apparently it's now found that a patient's eGFR naturally decreases as they get older. So our current Queensland Health Guidelines, which is slightly different to the Royal College, and these may change when it comes up and they review the Queensland Health Guidelines. But at the moment, if our patient is over 70 years of age, has a history of renal impairment, is diabetic, or is on metformin, then we need to have an eGFR within 1 month. So these are the new Royal College guidelines. They came out just this year. There is a link to them on our G Drive, and Clem has wonderfully done up a couple of books for us that actually live in CT. Ignore the title of this one, it's an old folder, but he's got them all in here. So this one's got the Royal College in it, and this one has all our Queensland health policies. to do with IV contrast, okay? So they all live on the bench in CT. So we've got our guidelines. And Chris has done up a really good one for us too, which actually goes through all the questions as well. So they're all there for people to read through. They're all on our G drive and they're all under the CT IV contrast folder. Now, one interesting point that I just wanted to cover is our bilirubin. So we do have one other type of contrast that we use in the department. It is bilirubin. We use it only for cholangiograms, okay? And it's important to be aware that it's very different to our other iohexyl contrast. And this is because where iohexyl is non-ionic, bilirubin is ionic, okay? And you need to be really careful that you don't give it as a bolus injection. So you can't draw it up into our injector and inject it that way. You can actually cause a patient to die.